So a very, very brief history of CRPS. Well, it's been known about since the 16th century. It was described by Hunter as a pain syndrome after knee joint surgery. It was talked about in the Napoleonic Wars. A musket ball, a soldier who was wounded by a musket ball experienced burning pain, and the burning pain was so bad his arm was amputated. And we really catch up with it more in the American Civil War, where it's described as a form of suffering as yet undescribed, but so frequent and terrible as to demand from us the fullest description. So the reason for putting those up is just to give you an illustration of what sort of levels of pain these patients can experience with CRPS. Now, CRPS has had a number of different names over the years. I've found over 30 different names. The ones at the top left-hand side, which are highlighted in yellow, these are the commoner ones that you will see: RSD, reflex sympathetic dystrophy, Corjaldic, post-traumatic alga dystrophy, shoulder-hand syndrome, Sudeck's atrophy. The reason I put this in here is that you may see these terms used in your patients or your clients' medical records, but essentially they're all talking about the same thing. And we have now classified all of these conditions as CRPS, or complex regional pain syndrome. The next most common name to be used is probably RSD, or reflex sympathetic dystrophy. So what's the cause of this problem? Well, essentially the causation is trauma. It can be anything: fracture, soft tissue injury, cuts, burns, nerve injury, and surgical intervention, which is of course controlled tissue injury. Just to say, this is a article that I helped write, which actually came from a medical legal case, where the medical legal case revolved around the fact that a patient had a very tight plaster of Paris on their arm, and it was always known that if you have too tight a plaster of Paris, that may be a cause of complex regional pain syndrome. Now, we looked at this in quite some detail because it would be obvious that, yeah, it probably does have a part to play, particularly with the swelling. In actual fact, what we found was at that time, there was no evidence that a tight plaster of plaster cast can lead to CRPS. And the spread of CRPS, this is often looked at in medico-legal claims, particularly where patients have a single limb involved. It's thought that CRPS actually spreads in approximately 7% of patients. Now, the range for this is extremely wide, from 2 to 15%. And the studies on which this information is based are not fantastic, but it does give us an indication that this can happen. And certainly in clinical and medico-legal practice, we do see patients who will start off with CRPS in one limb, and then it will spread to other limbs. The reason for that is not completely understood. So how do we diagnose CRPS? Well, we've talked a bit about the symptoms, and as we said, the major issue that patients have is pain, very severe, disproportionate pain. And we mentioned the other symptoms and signs that they have. Now, the Budapest Criteria is a criteria which is used in order to diagnose CRPS. It's not used that much in a clinical setting. In a clinical setting, when you read your patient's notes, it's basically going to say, you know, was in the pain clinic, was in the orthopedic clinic, query CRPS, might have CRPS, features of CRPS, that sort of thing. But it's very rare that in the clinical setting, the Budapest Criteria is actually applied. However, when these patients come to the medico-legal setting, it's very important to get some sort of standardized diagnostic criteria, and this is where it comes into its own. If we look through the Budapest Criteria, it's divided into 4 categories. So the first category to diagnose someone is continuing pain, which is disproportionate to any inciting event. Second category, you need to have one symptom in 3 or 4 of the following categories. So that's sensory, vasomotor, pseudomotor, and motor. Now, you don't need to write all of this down. These are freely available. We can give you a slide set if you wish, but it'll just give you an idea when you're reading reports with the Budapest Criteria and what they're talking about. So symptoms, as you know, are what the patient describes. They say, you know, I've got this, I've got that. Sensory ones, well, these are hypersensitivity. Vasomotor symptoms are temperature differences and color changes. Pseudomotor changes is basically sweating changes and swelling or edema. And motor changes, as we mentioned earlier, is reduced range of movement, weakness, tremor, dystonia, hair changes, nail changes, skin changes, etc. So in the Budapest Criteria, in that second category, these are symptoms. So in order to be diagnosed, you need 3 out of 4 of those categories positive, and the symptoms are what the patient reports to the clinician. Category 3, in addition to the above, the patient will need to have at least at least 2 or more signs. That is a sign in each of the categories. Again, sensory, vasomotor, pseudomotor, motor. Now, the difference with a sign is a clinical finding on examination. So it's not what the patient's telling you is wrong with them. It's what you can observe. Now, as the quick amongst you will notice, if you're asking a patient about hypersensitivity, on the one hand, that is a sign, that is an examination finding. However, you are reliant on that patient giving you factually correct information. So yes, we can measure temperature differences. We can see sweating changes. We can see edema. We can see various motor dysfunctions. But we are reliant when we do our pinprick and light touch testing, for example, that the patient gives us the correct feedback, and more about that a bit later. Now, the 4th category of the Budapest Criteria, you have a patient, they fulfill number 1, number 2, number 3, and you think tick, 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 yep, this patient very likely has CRPS. This is a good fit diagnosis. Category number 4 says that there is no other diagnosis that better explains the symptoms and signs. Now, that's very important. We're going to talk about that a little bit later when we talk about range of opinion in medico-legal cases. So just to say very, very briefly, the Budapest Criteria, they're clinical criteria and research criteria. The sensitivity of both of those is extremely high. So what that means is the likelihood that you will pick up a patient who has CRPS is 0.99, so virtually 1, which is very, very high. In terms of specificity, that is getting false positives. In the clinical criteria, it's about 0.68, but it's higher in the research criteria at 0.79. So it's with the research criteria, you're more likely to A, diagnose the condition, and B, diagnose it correctly. So how do we classify CRPS? Well, you're going to see this in your claimant's reports and in their medical records. So what I did here is I basically went to the ICD. Now, ICD, as I'm sure you know, is the International Classification of Disease. The ICD-11 is the latest one of those classification tables, and this is produced by the WHO, the World Health Organization. And essentially, it's a classification of all the different medical conditions there are, and all the medical conditions are given numbers and names and descriptions. And I've just taken this straight from the ICD-11 to go through this with you. So complex regional pain tolerance syndrome, or CRPS type 1. So description: CRPS type 1 is a chronic pain disorder that develops after an initiating noxious insult and usually affects one limb, but may spread to others. The pain is typically disproportionate to the inciting event and is associated with sensory, vasomotor, pseudomotor, trophic, and motor changes. Now, we've discussed that, and that is the large majority, 75 or at least 70% of cases of CRPS will be type 1 CRPS. And that is a good description, and that's pretty much what we've talked about before. There's another type of CRPS, and this is referred to as CRPS type 2. Now, the difference with CRPS type 2 is that this occurs where there is some sort of partial injury to a nerve or one of its branches. Now, that nerve lesion may be obvious or it may be not obvious, but in medico-legal practice, it's an important to work out if there has been an initiating nerve injury to be able to classify whether it is type 1 or type 2. There's also a third category for CRPS, and this occurs in about 15% of patients, and it's called unspecified here. We usually call it NOS, or not otherwise specified. And essentially, this is a bit of a cop-out, because we're basically saying, well, this patient doesn't strictly fulfill the Budapest criteria for a diagnosis of CRPS, but they're pretty much fit most of the criteria, and there's nothing else that we can think of that really would explain it. So they end up in this category. Stages, I'm going to go through this very, very quickly, and I'll tell you why at the end. The stages of CRPS classically are looked at as the acute stage, which is within weeks of the injury, a dystrophic phase within months of the injury, and an atrophic phase within months to years of the injury. Now, the reason I'm going to go through, just gloss over this, is that actually in practice, we don't always see patients going nicely through these stages as you would wish. And some patients will be stuck at the acute stage for a prolonged period of time, even months and years, likewise with the other two stages. So it is described, but not often seen. So let's talk about the pathophysiology. So what we're talking about here is what's the actual underlying mechanism? Why do you get CRPS? Well, the simple answer is there is no single pathophysiological mechanism. You've got a heterogeneity of symptoms, a wide variety of different symptoms, and we simply don't have a single unifying theory that says CRPS is caused by X. What we do have is multiple mechanisms, and the two at the top, which is central sensitization and peripheral sensitization, essentially this is where you have hypersensitivity of the nervous system, and in simple terms that tends to be the most likely explanation. Other explanations are altered sympathetic nervous system function, altered levels of cytokines, genetic factors, psychological factors, and other causes. Now, moving on, how do we investigate these patients? Right, so remember at the beginning, we said in the Budapest criteria, number 4 is the absence of any other diagnosis to explain the clinical findings. Well, the investigation we do on CRPS purpose is actually to rule out other conditions. So, for example, there's an array of blood tests there. We're looking to see, does the patient have an inflammatory condition, an inflammatory arthritis, a liver problem, a kidney problem, a bone marrow disorder, some other cause that may or may not explain those symptoms, or a peripheral neuropathy. That's a good one to rule out. Other tests that are undertaken, MRI scans, which show certain abnormalities, X-rays, likewise, which can show patchy osteoporosis. And then there are a number of other investigations that are undertaken. So electrodiagnostic tests, bone scanning, bone densitometry, thermography with infrared thermography scanning, sweat tests, sympathetic nervous system block. The important other reason for putting these investigations up is that in cases of CRPS, it can be said, well, this patient, yes, they may well have all of these symptoms and signs. They may have the Budapest criteria, but when you do the investigations, all the investigations are negative. Well, they can be in some patients. There is no specific pattern to positive investigation findings in CRPS. So what we use the investigations for really is, as we said before, to rule out any other underlying causes, or if they are positive, to maybe give us some extra diagnostic information. So next we're going to have a look at the treatment of CRPS. So it's an MDT, a multidisciplinary team approach. And the easiest way to summarize the whole of treatment for CRPS is to look at something called the Stanton-Hicks overview. And essentially, this is what the Stanton-Hicks overview is. If you look down the middle, this is called a care continuum. You make the diagnosis of CRPS. The mainstay of treatment tends to be medication and some psychology. And then very quickly, the patients are put into a rehabilitation pathway, and this tends to be with a specialist pain physiotherapist. Down the sides, on the left-hand side, you've got much more specialized psychological interventions. And on the right side, you've got interventional pain management. We're going to talk about all of this, but this is the intravenous blocks and all of that sort of thing. And basically what you're trying to do when you treat patients who are diagnosed with CRPS is you're trying to guide them down the middle of this care continuum until hopefully we get to a point where you get excellent response. If they have a relapse or a problem, then you can go back to the top of the cycle and start again. But that overall is a summary of the sort of treatment approaches we use, and we use them concurrently to try and treat patients. If we look at patients and your claimants, the sorts of medications they're going to be on: anti-neuropathic medications, so things like pregabalin, gabapentin, duloxetine, amitriptyline, anti-inflammatory medications, weak opioids, strong opioids, so things like tramadol, oxycodone, morphine. Some patients end up on ketamine. They get given steroids, vitamin C. Sometimes they're on medicinal cannabinoids. So your patients can very often be on quite a significant number of medications. And the reason this is important is that, firstly, obviously, we need to give patients medications that help them with their pain, improve their function, allow them to their physiotherapy. But equally, we need to bear in mind that all of these medications are associated with potential adverse effects. So the sorts of common adverse effects with these medications is feeling tired, drowsy, sleepy, dizzy, that sort of thing. And it's always important to bear that in mind, what sort of doses patients are on and what sort of benefit they get versus the side effects. We do have some procedures that we can offer patients. So for upper limb CRPS, we do sympathetic blocks. The main place is in the stellate ganglion, but also in the cervical nerve roots. And that can be with local anesthetic, with steroid, with pulsed radiofrequency. And similarly, we can do sympathetic blocks in the lower limbs. And this is anatomically similar, but looking at different nerves. So that's the lumbar sympathetic plexus and maybe the lumbar and sacral nerve roots. Some patients end up having intravenous guanethidine blocks. This is where we put a tourniquet on the patient's limb, we exsanguinate it, and we fill the limb with local anesthetic and guanethidine or ketorolac or other medications. We can talk about that later if you wish. They're actually not recommended that patients have these intravenous guanethidine blocks anymore. However, having said that, there are some patients who, for whatever reason, actually respond quite well to them. So they You know, if we have a patient who's previously had them and responds, then we will continue to offer it to them. Other treatments that are offered include infusions. So we use infusions of things like lidocaine, ketamine, clonidine, and various other combinations. And the idea there is that you will infuse a patient with this usually once a month. And the idea is to switch off a lot of the overactive pain receptors and try and calm them down. Advanced pain management procedures, some patients, I'd say, I don't know, certainly less than 10% may end up with more advanced treatment options. So this is things like spinal cord stimulation, dorsal root ganglion stimulation. So these are essentially implantable devices where the electrodes are implanted over the dorsal horns of the spinal cord, and they give a counter stimulation. If you look at the picture at the bottom left, you'll see a little device, and essentially that is a computer with a battery pack, and that delivers an electrical stimulation, which, if you look at the middle one, that's the electrodes going up next to the spine, and the picture on the right, that is the leads that you can see under X-ray. Psychological treatment, very important, and we saw this when we looked earlier at the Stanton-Hicks overview. So this is often given by clinical pain psychologists, who are psychologists that specialize in patients with pain issues. And there's a number of different things that can be done: counseling, CBT, relaxation, biofeedback, and those techniques can be extremely helpful. And I've actually put last physical rehabilitation therapy. And the reason for that is that the way most clinicians look at the treatment of CRPS is that we have multiple different treatment options, as we've gone through. But ultimately, the aim of the game is to deliver a patient to a pain physiotherapist who will then be able to create a bespoke treatment program, which will use things like a graded exercise program, graded desensitization program, motor visualization, and a whole bunch of other techniques that are used. So that is our ultimate aim, is to deliver a patient with pain as well controlled as we can, with minimal side effects, to our physical therapist, who can then create a program, and then that patient can go home and then do that program as a home exercise program themselves. My experience in clinical practice, outside the medicolegal sphere, I would say the majority of my patients are post-operative, particularly things like hand surgery, ankle surgery. From a trauma point of view, I will see anything from literally people who've just turned their ankle on a skateboard or twisted their ankle, all the way up to very significant traumas where they almost have they may have had their leg crushed and that sort of thing, and anything in between. Treatment wise, what we do find is some patients actually do quite well just on medication, and this tends to be when you pick them up early. But for those that don't, certainly getting them plugged into a multidisciplinary treatment program as soon as possible is very, very important. In my practice, in the NHS and in the private sector, if we get patients with CRPS, we tend to get phone calls or urgent emails from orthopedic surgeons and GPs who say, I think this person might have CRPS, please can you look at them? And usually they've literally developed it for a few days or weeks, and we can get in there and treat them. And what we find overall, I would say as a generality, is the earlier the diagnosis, the earlier the treatment increases the likelihood of successful outcome. It is an unfortunate thing that with our medico-legal process, unfortunately, many of the patients that I do tend to see can be diagnosed relatively late. By the time I end up doing a report on them, they may be anything between 3 and 5+ years down the line of having had the injury or having had the diagnosis, and very often have quite patchy treatment, unfortunately. But from a clinical point of view, if and when we see these patients, the earlier that you get them, the earlier that you get to them, the earlier that you start them on medication, the earlier you start their physical rehabilitation, you are much, much more likely to get a good positive outcome for them.